As the implementation of the Affordable Care Act, or Obamacare, progresses, the Department of Health and Human Services is taking away the religious freedom that all Americans are guaranteed by the First Amendment by requiring that all employers, regardless of religious conscience, provide all forms of contraception to their employees and even to minors without the knowledge of their parents. In response to this assault on the Constitution, Catholic leaders are stepping up and are searching for what can be done within the bounds of the law to deliver quality health care that follows the ethical and religious directives for Catholic health care services. The Make Straight the Pathway Conference was held in Houston, Texas in March of 2013 on the campus of the University of St. Thomas to shed light on the critical problem of providing quality health care and protecting everyone's religious freedoms.
Throughout the morning and throughout the day, we have heard an awful lot about our Catholic healthcare system, our religious directives, and things of that nature. And in a great way, that's sort of like an airplane. We've been flying up here at the 10,000 or 20,000 foot level. And what I want to share with you today is how a group of dioceses in the state of Texas have brought all of that down to the runway level, to the ground level, and what we're actually doing to help each other as dioceses and what we are doing to help each other as individual Catholic laity, priest, vowed religious, and whatever, to live through and to work with what is now known as the Affordable Health Care Act. Okay? And I am not tech savvy, so if this doesn't work, we'll think. Back in 1989, I made a presentation to the Texas bishops at that time about having a consolidated health care plan. And everybody said, yeah, that's a good idea, but it was something that they could brush off. They continued brushing that off all the way through and up to about 2005, when they finally decided, I guess sort of what, biblically, the judge that said, let's just give this old lady whatever she wants so she'll quit coming back to my court. Okay, well, that's kind of what they did with me. They said, let's let Jim Smith form a committee and just see if he can get anything up and off of the ground. Well, when we did that, we began a process of actually going and visiting in all of the 15 dioceses of the state of Texas to find out exactly what they were doing with health care. And we sat down and personally visited with as many bishops as would see us. Not all agreed to, but as many that would see us. But we did visit with someone on their staff that dealt with the issue of health care to determine what they were. And what we found out is that all of these dioceses were simply all over the place in the way they described various types of classifications of employees and all like that. So the first thing we had to do was to come up with a broad enough definition that we could go back and everybody could buy into what we were trying to define in the way of health benefits. We came up with classifications of actively ordained, actively preordained, which is seminarians, okay? Active other religious orders. And that was a significant component of that because each of the dioceses in the state of Texas deal with the health care for religious orders in different ways. A lot of them actually have the religious orders stay involved in their own religious order health care plan and simply pay a premium towards that in order to remove those experiences and things of that nature from their health care plan. Some of the others were treating the religious orders, both brothers and sisters, on a lay equivalency and were bringing them into their plan because they needed more numbers into their plan. So we actually had to spend quite a bit of time discussing how religious orders were going to be taken care of. And then, of course, we had the active lay employees. And then we had to deal with the issue simply because our church, our body of law, states that canonically a bishop is responsible for the ordained in his diocese until their death. We had to deal with two separate classifications of that. We had to deal with the actively ordained or retired ordained that had Medicare and the retired ordained without Medicare. Because for a lot of priests during the actual that were ordained in the 30s and the 40s, okay, and into the 50s and even into the early 60s, they opted out of Social Security. You would be surprised at the number of elderly priests in the state of Texas that actually opted out of Social Security, because ordained ministers, regardless of the denomination, have the right to opt out of Social Security. So quite a few of them did, which means that from a health care standpoint, those that opted out of Social Security became 100% responsibility of their diocese of incarnation, simply because there was no offset for Medicare Part A and B to be available to them. So that added a dimension to planning a health care program that would be available throughout all of the dioceses that would meet everyone's needs. Okay. No small matter. I think it was referenced in several of the presentations, particularly most recently by Douglas, that you can get an agreement with one bishop and the very next bishop will not even see that issue exactly that same way. So there's no real agreement sometimes between bishops in that. Okay? The Catholic Employee Benefit Group began to try and address these things based upon some premises that were going on in the state of Texas at that time. Within healthcare, and it still continues within healthcare, the trend rates were double digits and the costs were doubling almost every 3 years for some of our dioceses. The costs that we were paying for health insurance was outpacing our offertory and the ability to increase tuitions at our schools. Now that was another key issue that we had to address, was the cost of health care for Catholic education and Catholic educators. Because of that one phrase there, the ability to increase tuitions to keep up with that cost. We were seeing quite frequently schools that were trying to develop ways, even within a diocese, of opting out of a diocesan health care plan simply because of those costs. Okay? Then we had multiple small individual groups. Every diocese had its own little plan. They had very little leverage with insurance companies, with insurance brokers, with loss carriers. You would actually see what we saw was that the average life of a health insurance plan at the diocesan level, even in dioceses as large as Galveston, Houston, they actually were changing carriers because of loss ratios every 4 to 5 years, okay? Because the only way they could get rid of some of that baggage of heavy loss ratios was to actually change carriers on a frequent basis. So again, the Texas bishops formed a committee, and with the assistance of the Kennedy Foundation out of Corpus Christi, we engaged some outside consultants to help guide us through this process. The outside consultant's primary job was to take all of these 15 different health plans that we had in existence in the state of Texas and to develop a benefit-neutral plan that would be acceptable across the board to all of the bishops. We had to develop that for medical, prescription drug, dental, life insurance, accidental death, and dismemberment. Okay? Now, the last two there, life insurance and accidental death, we had several dioceses in the state of Texas at that time that did not provide life insurance benefits for their employees except through their health plan. Okay? They had minimal coverage through their health plan, but they provided no other group life insurance benefits. So that had to become something and part of what we were discussing in putting together a group. Then one of the key things that we decided to do was to obtain an outside actuarial evaluation of the proposed plan. Most of the dioceses at that time were using the brokers for the insurance companies to give them projections of what their costs should be based upon their claims experience and things of that nature. Well, of course, there's a built-in conflict of interest there, so we decided that going forward, if this was to succeed, we would include an actuary from an outside firm to look at all of our trends and costs. In 2006, we were actually successful in getting 4 bishops to agree. Now, that has to be a record. 4 out of 15 still have, I mean, that's a little over 25%. That has to be a record of getting 4 bishops to agree that going forward, they would attempt to put together a common health care plan for their diocese. The bishops that participated at that time were Bishop Yanta. He has since retired from Amarillo. Bishop Rodriguez, who is still serving in the Diocese of Lubbock. Bishop Carmody, who is retired from the Diocese of Corpus Christi now. And Bishop Corrada, who was the Bishop of Tyler at the time and is now serving in the Diocese of Mayagüez in Puerto Rico. Okay? What we did is we put together a Texas nonprofit civil corporation to begin this process of bringing these dioceses together. Then we decided that each subscribing member, yes, we do have a subscribing member clause in ours, that each subscribing member would be represented on the board of directors. This was another key that we had to deal with, was to how to distinguish ourselves from some other groups out there, particularly the California group, the Rita Trust in California, where basically that is run, there's a group of dioceses together, but the larger dioceses in California and LA basically mandate what everyone else is going to do, and they all just kind of salute and fall in line. Well, we did not want to get that type of a dynamic going in the state of Texas, so we developed this model of each of the dioceses or whoever was participating in this plan, and we opened our plan up to anyone who is actually listed in the Kennedy directory that is covered by the current group ruling of the IRS for Catholic entities, okay? So we could include in our plan not only dioceses, it has the biggest appeal to dioceses, but we could at that time include in our plan Catholic universities and religious orders and others that were listed in the Kennedy directory and recognized under the group ruling, okay? The board of directors then oversees the general operations and determines the benefit structure. The current claims administrator is Web TPA. The stop-loss carrier is Aetna. The network that we use is Aetna Signature. And then United Concordia provides us dental benefits. Now let's talk a little bit just about that portion of how we had to get to that, okay? Because there's a lot of PPO networks out there that have broad coverage, but they are very limited in their coverage in rural areas, okay? So we had to come up with some type of a plan and some type of an organization that would make sure that the priest serving in the small parish in Winsboro, Texas, in East Texas, would have as much access to quality health care and providers as the priest that was serving in Corpus Christi that had the Christus Spawn health system all over the city. It was extremely challenging in that because we had to actually look at a lot of varying factors in there, and then we had to engage outside consultants in those areas that did not have penetration to go and negotiate a provider network in those smaller rural areas so that those people in those areas would have access to the program. No small feat. So as we go together and as we continue the dream of the Christus Medicus Foundation and what a lot of us are here for, of coming up with a united healthcare plan for the Catholic Church and a national plan for the Catholic Church, there are significant issues not only at the Episcopal level of getting all, 190 plus dioceses in the United States, to getting all of them to agree to what needs to take place, but there are also administrative issues of how to have a variety of networks, because no one single network is going to be the answer in any particular area of a state, more or less throughout the United States. Now, here's another issue that we found that was very thorny in all of our dioceses, in all 15 dioceses. The board sets the overall premium based on a negotiated administrative cost, including stop loss and all of the things that you would consider going into a premium calculation. Then you get down to the next line that says each diocese determines the methodology for assessing premium and contribution rates to their local diocese. Now you think, okay, if your premium is $500 a month per person, per member, per month, then that's what would be there. No. We actually found that in the 15 dioceses of the state of Texas, 12 of the 15 dioceses at that time were using the health insurance premium and a calculation above actual cost to subsidize the diocesan budget. Okay, let me run you by that again. They were adding another $50 to $75 per month per employee to cover operational costs within the diocese above the actual cost of the health insurance plan itself. And some of them said, okay, I agree with what you're saying, Jim, but I'm not giving that up. Okay? That was unique. We had one diocese in the state of Texas that joined in the 4 in 2006 when we became a reality, that their premiums was so high that 7 years later, they have not changed their premiums in 7 years, and they're still meeting the minimum requirements of the plan to fund. Okay? Wrap your arms around that. 7 years later, they have not changed the premium billing to their locations because they were so high, and we've been able to control the cost, that they have not increased their cost at all over a 7-year period. Okay? Then the other thing that we found out is that some dioceses were using their brokers to do their billing for them, and some dioceses were doing it internally. The dioceses that were doing it internally had actually a large amount of high receivables, simply because there are parishes and everything else that will pay every bill that they have out there before they actually pay the diocese, all right? So there was receivables accumulating in some of those dioceses. We had a couple of dioceses that had over $1 million worth of receivables in health insurance being carried on their books at that time, okay? Another unique type of thing. So we came up with a system of developing a billing program through the Catholic Employee Benefit that is optional to the diocese. They can continue if they want to with their own program, but it's optional to the diocese. We instituted that. All 4 dioceses that participated bought into it, and we currently bill over 200 parishes and or schools each month, and we are now at a 100% collection rate each month on that premium, okay? Something quite uncommon for health insurance in the state of Texas anyway. I'm not sure about where other places were, okay? This year, we are going to conclude our 7th year of operation. Over the 7-year period, for those who have participated, the actual cost, the cumulative premium increase over that 7-year period has been only 13% in that 7-year period that we have been in business, okay? What we have done in order to control that cost is that we have gone into what has been recommended here today and talked about this morning, moving away from just the simple fee-for-service type of concept in order to create a quality of care for the laity and the priest and the vowed religious in our diocese, a quality of care that pays dividends going forward because we're managing health on the front end as opposed to on the tail end. Now, this is unique because in the previous programs, it was simply pay your premium, let the people go to the doctor. They submitted the bill to the TPA. The TPA judged it according to whatever the policy was, paid the bill, sent the billing difference to the participant, and we were through with it, okay? But we have actually gone through and identified and are working with various population groups now within our group to improve the quality of health care in that. I'll give you a very personal example of that. The Diocese of Tyler on November the 28th, although we're only 25 years old as a diocese, just installed the 4th bishop of the Diocese of Tyler. Quite unusual in a 25-year period to have gone into 4 different bishops, okay? But in the Diocese of Tyler, when we sat down and visited with Bishop Strickland regarding the health care program, I had the ability to inform him that we have 92 priests serving in the Diocese of Tyler. A great blessing because we only have 68 parishes and missions. So we are definitely on the cutting edge of being able to provide more priests for our locations than many dioceses. Of that 92 priests, we know for a fact that 39 of those priests have diabetes. Okay? We have another, that's a high significant portion, isn't it? Yeah, if you're doing the math, you say, whoa, wait a minute, a third of your priests are diabetic? Yes, that's absolutely true. Another shocking portion of that is of those that have diabetes, the 39 that have diabetes, 32 also have high blood pressure. Not uncommon in diabetic conditions to have both of those. Independent of those, we have another 37 priests that are diagnosed with high blood pressure. So I could confidently tell the 4th bishop of the Diocese of Tyler that 3/4 of his presbyterate, as he entered office, had serious health issues. Okay? Now, we've done that simply by, instead of just paying the bill and all like that, collecting data and working with that data and developing programs to help that. We now, with the help of our Catholic health systems in the Diocese of Tyler, which is the Christus healthcare system and the Trinity Mother Francis healthcare system and the St. Joseph system, we're very fortunate to have 3 in the Diocese of Tyler. We are able to work with these groups, and we are able to, from a peer position of doctor to doctor, we are able to get physicians to call doctors that are treating some of these priests that are diabetic, that are not refilling their insulin prescriptions and things of that nature, to encourage that doctor to call his patient in, bring him into the office, and make sure that he's absolutely following the routines that he needs to do. Now, in doing this, we are beginning to see that the claims trend is going down because we're spending some time up front within all 4 of these dioceses. I use Tyler simply because I'm very familiar with those statistics. But within all 4 of these dioceses, we're doing the same thing. We have instituted mandatory wellness programs for all of the priests, vowed religious, and laity within these dioceses, okay? They are required to have an annual physical each year. They are required to notify each diocese that they have their annual physical. At the beginning of the year, we send a little form out that basically says that the doctor signs that Jim Smith showed up on February the 12th or whatever it was and received a physical. No other information is transmitted to us except that he did show up and get his annual physical, and that is sent back to us. Now, we require that not only medically, but we also require that dentally because we've come to understand that a lot of dental problems can significantly impact the medical problems that are out there. So they have to get two examinations each year. We designed into the program a wellness benefit, absence of co-pays and deductibles of $500 per person per year that would cover a basic annual physical sufficient enough that we could get information from them to be able to treat. Okay? We have been able to do this because, again, we're moving in the direction of trying to do a better population management in order to control costs, but also to improve the quality of care that our employees, priests, and vowed religious are receiving from their benefit program. Again, we have an annual audit. At the end of the 7 years, what we have found is that we're beating our trend rate. You can see where the costs are going up and where actually we have stood within that, okay? So it gets back into moving kind of a paradigm shift of saying, okay, here's your health insurance program, just do the best you can with it, to providing education on what their benefits are, how to maximize their benefits, and the insistence that everyone take an annual physical. Question's going to be asked, if they don't take an annual physical, what do you do? Well, we actually now penalize them, all right? That was kind of a unique thing. So if you, in 2013, received your annual physical, then fine. In 2014, your premium stays, whatever your participation level is the same. If you do not get an annual physical in 2013, then we increase your out-of-pocket cost on a monthly basis for your portion of the premium by $50 per month until you do go get your annual physical. It generally only takes 1 month of that in order for them to go into the doctor and say, you know, this is free anyway, I'm going to go ahead and sign up for it, get it done, and send that little thing to Jim Smith so he'll quit sending me a bill for $50, okay? Now, a lot of people probably say, hey, Jim, that's really not fair. Well, it may not be fair, but it works, okay? And if we're going to lean on the sideness of work or fair, let's lean on the sideness of it works, okay? Because we're getting people's attention with that. And that applies to our priests and our vowed religious too. We don't provide an exception there for them. If Father doesn't get his annual physical, we increase his out-of-pocket cost each month by $50. Trust me. I have never had anybody go more than 2 months without getting an annual physical as a result of that, okay? All right. So some of the things that we're doing to offset that. Average monthly cost is clearly there. Here's something else that we have done, and then we'll get around to talking about how we are incorporating the Patient Protection and Affordable Health Care Act and the discussions that we're having. We have looked at other opportunities because as a church, I'm sitting in Tyler, Texas, and I'm noticing I've got 68 locations, all right? Of those 68 locations, I have 17 parishes that have an annual offertory collection of less than $50,000 a year, okay? So we're servicing some very poor, economically disadvantaged Catholics. So how do we reach out and do something for them? So we hit upon this, we've got a prescription drug card that they're all over the nation now. Everybody's got American Airlines will give you a prescription drug card, for God's sakes, if you sign up with AA.com, okay? But we have taken that prescription drug card and we have made those available in our parishes, and we provide education to the people that says this is not an insurance, but if you go to the doctor and they give you a prescription, this will give you a discount on that prescription, okay? Currently, I have about roughly, I'm nearing close to 15,000 of those cards in use in the Diocese of Tyler right now today. I'm not sure what the other dioceses are doing, but all of them are there. And we're providing that type of service to the poor people of our diocese, okay? Again, we explain very carefully, it's in English and in Spanish, that it is not insurance, but if you take this and the doctor gives you a prescription for the baby, and you go to a pharmacy, and Walmart and Kmart and most of the H-E-B, Brookshire's, all of the big pharmacies, CSV, Walgreens, and all like that, honor this thing and will give them a discount on that. Well, that helps them. It may not be a large discount, but even if it's 10% knocked off of a $50 prescription, that's $5 that they can spend doing something else with. So it is significant, and it's being widely and appreciatively received at our local parish level, particularly by the priests who want to address some of the social justice issues within their communities. Been very well received. Okay? That just basically goes over the prescription discount. Now let's deal for just a second, before I run out of time, of what this group is doing with the Patient Protection and Affordable Health Care Act, and why I think it's important going forward that more dioceses throughout the United States, not only here in Texas, but more dioceses throughout the United States consider doing exactly what we have done here in Texas and offer the opportunity for collaborative association in the providing of health care benefits to their employees. Okay? We have had an impact study done for CEBG on all 4 of the dioceses. We hired an actuarial firm outside to give us an impact study on what the Affordable Health Care Act will mean to each diocese. Okay? I want to tell you it's absolutely frightening what it's going to mean. By the time we go from where we have a policy that says the annual maximum is $2 million to unlimited and all like that, there are some staggering costs built into this thing that are not just related to health care. We can handle the health care because we can administer the population and all like that, but there's some cost built into this thing that's not just related to health care, and that this board is currently discussing. We have additional board meetings to discuss basically how CEBG is going to respond to the social justice issues that are built into the Affordable Health Care Act that a lot of people are not aware of. Okay? I'm going to give you just one today. We have all understood that the Affordable Health Care Act has decided that affordable insurance is going to be based upon 9.5% of the W-2 wages reported for each employee. So if their cost is 9.5% or below, then your plan is going to be deemed as affordable under the Health Care Act. Okay? Let's take an average church employee in the state of Texas, and we find that the average throughout the state of Texas for church secretaries, those type of things, the average pay is $28,000 per year. Okay? Affordability on that is going to be roughly about $2,300 per year for cost. Now, this is what they're paying out of their pocket for their actual health care, not the actual total cost of health care, but what they're paying out of their pocket. So that works out mathematically to about $197 to $200 per month. Okay? So if your plan and their cost falls below that, then under the Act, you're going to be deemed as affordable. Now, here's where the rub comes in, and here's where the social justice issue comes in, and here is what we are not being told about the advantages of this act for the poor. This act is actually going to be more punitive to the poor than what we currently have in the way of a system today. Okay? I will tell you why. Under the idea of people being able to go to the state exchanges, and as of this moment right now, I do not know a single state exchange that has published what their rates are going to be. You can do some interpolation about what possible rates are going to be and things of that nature. But let's say this same family is right now paying for the employer's portion, the employee's portion. his diocese had said, you're going to pay $100 a month. Okay, he's making $28,000 a year. That's a pretty sizable hit, but it falls within the range of being affordable. Okay? Now let's say this same diocese is providing health care for his spouse and their 3 children. So this employee now has 4 dependents on there. And say the average of that health care comes to $1,400 a month. All right? Now the employee's paying $100 out of his pocket, and somehow he's got to come up with another $1,400 to cover his whole family. That's a total of $1,500 a month. What he pays for family coverage is not considered in the calculation of the Affordable Health Care Act. So let's say they look at it in whatever state they're in, and they say, well, maybe we can get insurance for the spouse and the 3 kids cheaper at the exchange because we're within that range of 133% to 44% of the poverty level. Because at $28,000 a month, $28,000 a year, they are at the 133. So we're going to be eligible for subsidies from the federal government. So we'll drop the coverage that we have here and we'll go to the exchange and we'll get coverage because we can get subsidies and possibly give us more disposable income and still have health care coverage through the exchange. Here's where it comes. If your employer's plan has been determined as affordable, then your dependents are not eligible for federal subsidies under the Affordable Health Care Act. Let me repeat that. If your employer plan has been decided as affordable, your dependents can go and purchase insurance from the exchanges, but they would not be eligible for federal subsidies. So it might well mean, and since they don't mean, I don't know whether they're going to get good care, a good premium, or a bad premium. But here's the other side of this. The exchangers are going to offer what's commonly known now as a bronze plan, a silver plan, a gold plan, and a platinum plan, and it's all based upon the level of benefits that are in there. All right? The bronze plan is the basic thing, which is 60%, which means that they can have an individual deductible of as high as $1,200 per person and a family deductible as high as $6,250 per family. So this same group goes from whatever plan the diocese has or whatever plan the employer has, they find out they're not eligible for subsidies, okay? So their cost is either the same or a little bit. They may not have as good a plan. Because here's something that is absolutely true in almost every aspect of life, but it's definitely true as we plan health care. Money never disappears. Money simply changes pockets. Okay? So if the cost of health care is X and they go to the exchange, they may get a cheaper premium, but what they've done is they have changed a cheaper premium for higher deductibles and higher co-pays and higher everything. So the money remained exactly where it was, but it changed pockets. It went from the pocket of the employer and the employee into the pocket of the other side. So the money doesn't change. So Catholic Employee Benefit Group has begun a process and a dialogue of how do we communicate that and how do we retool our coverages in order to make it so much affordable that we don't actually put our employees in the position of having to choose one or the other and then finding out they're not qualified for subsidies. And that's not just in a diocesan or a Catholic relationship. IBM or any other employer out there that's providing coverage, if it's deemed affordable and their family care is high and the family tries to go get it somewhere else, they're going to have this same issue to deal with. The final issue that we're dealing with under the Act is the part-time employees. Under the Act, as you well know, they're going to take the total number of your part-time employees and the total number of hours that you have, and they're going to calculate that, and there's a formula in there that if it reaches a certain level, then each employer will have to provide coverage to their part-time employees. Okay? So that's an issue that you have to have. And there's so many part-time employees equals so many full-time equivalents, and those full-time equivalents would also get health insurance, and they have to be there for a stability period and maintained on your policy for a minimum stability period of at least 6 months. Now, all of this is also adding additional cost to your diocese and to your churches, because there's additional cost for calculating all of these benefits. There's additional costs built into this that it doesn't matter what our Catholic policy and our religious freedoms say, we're going to be subject to that same level of penalties and that same level of additional costs for accounting procedures and all like that. The problem with this is the more this thing costs, the more the church, the diocese, and the smaller locations are finding that their budget for ministry is shrinking. There is not a single thing in the Catholic Church that isn't paid for by 100% of the contributions that come from you as individual Catholics sitting in the pews each and every Sunday. Healthcare is that way. The accounting is that way. Youth ministry is that way. Everything depends upon your contributions. As this act is implemented and the costs go up on this side of the ledger, something has to be squeezed. We're dealing with the issue now of trying to maintain that as well, so that our diocesan bishops, while they are facing increasing costs, no question about that, are going to be able to do it in such a way that they do not sacrifice outreach ministry of the parishes and the diocese. It's something that I just want you to be aware of as we move through this process. It's something that I feel very important about, and I think one of the answers, and I believe Michael and Tim and a lot of you here will say, one of the answers is encouraging more bishops to give up the mentality of independence as the bishop in this area alone and join into these type of organizations such as the Catholic Employee Benefit Group in the state of Texas to provide health care and to provide it in such a way that it can be managed more effectively than having 190 some odd individual health care plans out there throughout the United States. It's something that we just simply propose for your consideration. We're proud of what we've done. In 7 years, we've held our costs down, and we've accumulated slightly over $1 million worth of reserves. And that's 4 very small dioceses in the state of Texas were able to do that by developing commonality and understanding of one another and collaboratively working with each other. It's possible elsewhere. The story just has to continue to be told. Just like the story of this Affordable Health Care Act, the religious freedom stories and all of that keep going forward and have to be told. These type of stories have to be told. I thank you for your attention, and I appreciate your kindness today. Thank you very much.
Hi, I'm Jeff Gardner, and on behalf of the John Paul II Life Center and the Christus Medicus Foundation, thank you for watching this presentation. The need for more crisis pregnancy centers and Christ-centered medical practices throughout the United States is critical and ongoing, and we'd like to encourage you to get involved. Before you do, there are a couple of important takeaways that we'd like to leave you with. First and foremost, develop a strong and clear vision of what it is you want to create. Be sure that you understand the distinctions between a crisis pregnancy center, a family practice clinic, an OB/GYN clinic, a multidisciplinary medical practice, or a sonogram center. Familiarize yourself, too, with the not-for-profit laws as they pertain to health care in your state. John Paul II Life Center operates within the state of Texas. Your laws may vary. Also, before you begin either to explore a crisis pregnancy center or a Christ-centered medical practice, get the blessing of your bishop. Get a committed and unified board. If you can, get the cooperation of your local Catholic hospital. Organize and identify physicians who can be key in helping you getting your project off the ground. Develop a strategic plan, and within it include the right professionals, those that you'll need to advise you in all aspects of your endeavor. Familiarize yourself with the fundamentals of fundraising, communication, and education. Everyone involved does not need to know how to do everything, but everyone involved should know about everything that needs to be done. To open a Christ-centered medical practice, understand the financial operations of a clinic. When considering the financial arrangements needed to establish a clinic, it has been our experience that the first-year costs, including salaries, is a minimum of $500,000 and can be supported by a recruitment agreement for a physician with a cooperating hospital. Also, care should be taken to consult with an appropriate practice management company to assist you in setting up the medical clinic and to get the correct assistance with licensing, credentialing for hospital privileges, and third-party contracts, as well as billing and collections with the best electronic medical records and healthcare information technology available. Right now, a national platform is under development to include a service company that will help take advantage of economies of scale so medical clinics and pro-life centers across the United States can be created. For more information, please contact us at Kimberly@jpiilifecenter.org. That's Kimberly@jpiilifecenter.org.